can survive without pacemaker and كده. But we have not tried chloroquine, hydroxychloroquine.
Is there a cutoff heart rate يعني below 100 above 100?
لا اللي هو what she mentioned I think انت قلتيها اللي هو 70 وال 55 لكن if this is if
2 weeks old how can you assess?
لا نو سيمتومز الهارت فيلير هم بتوع الاطفال بيعرفوا انتوا بتعرفوا كويس قوي الكالر الموديلنج في حاجات كتير قوي بالظبط والكيو ار اس if you find the white كيو ار اس complex على طول يعني.
But usually, no. My comment, just quickly. My comment is why is catheter if the patient's heart rate is more than 55?
What if?
Why do you put the umbilical catheter?
Umbilical catheter to get ready for anything
Let me finish,
which you can.
please.
Okay.
Why you put the catheter? We don't need to put any invasive things in the heart unless the patient is symptomatic or his heart rate is below 50. In this case, yes, but as long as the patient is fine, ECG is okay, you do ECG, things are fine, I mean, it's stable. I have seen patients in Ireland and somewhere else when they have rate 40, and still, as long as the patient is stable,
Yes, we saw.
better to watch.
هي المشكلة انك لو ما حددتش الامبلايكال كاستر بدري بالظبط. حطها اصلا انتوا بتحطوها كويس قوي وشاطرين قوي يعني كنت يعني كنت بدرس الناتولوجيست البراديكارديا والتاكيكارديا فبليسنج امبلايكال كاستر بالنسبه لهم ولا حاجه كشغل اليوم صح؟ مش حاجه كبيره فهي بتبقى ليا لان انا مش عارفه هيحصل ايه في العيل البريباريشن لان فينس بانكشر بقى وحط واير من الفينس اكسس يعني it can end the life of a child and I saw this. So الامبلايكال كاستر is very good easy simple
for expertise.
لا ولا اكسبرتيز ولا حاجه دي هي شوفيها مره على فيديو هتعرفيها.
stable.
Regarding the hand repair and so on, I think what I recommend is that what we used to do like before now, that we do joint clinic with your setting. We go to the clinic together and then make a decision that should be done together. Once the patient are feeling that bradycardia or any query about fourth chamber if there is any problem, so in that case they invite the setting and we do that together. So
multidisciplinary. يعني that's the importance of multidisciplinary work with the rheumatologist. يعني طبعا I think the take home message in identify early the first pregnancies that we have Dr. Huda, Dr. Hanifa. How can you know?
Nobody knows.
Okay. And then going forward, the subsequent pregnancies, patients should get hydroxychloroquine.
And actually, we don't leave the mother. We saw her every 2 weeks, 3 weeks. Even it's normal till we reach 32 weeks. When we reach 32 weeks, so we are now in safe side, and we can tell her complete, and we see the patient
After delivery.
With general teaching to medicine, don't do anything intervention-wise unless it's indicated. The patient has symptoms, whether it's temporary or permanent. Yeah, very, very important.
دكتور شحاتة عندها
خلاص عندنا سؤال واحد بس.
بس هل بالكتينس batches of pacing doesn't make difference في planning في situation like the دكتور ميرفت said لو احنا عندنا بالكتينس batch ما اعرفش حضرتك اكسبيرينس بتاعتك؟
انا عملتها قبل كده.
اوكي.
لازم العيل يبقى سيديتد لانها از فيري بينفول.
percutaneous spacing.
transcutaneous spacing وبعدين مش موجوده على طول يعني.
انا عارف ان هي availability question.
Spacing, this is temporary. Don't even think about it. Yeah, transcutaneous spacing emergency. Don't even think about it. لأن don't use it unless it's يعني.
I mean أنا أقصد it doesn't make difference في decision زي في حالات اللي هي يعني هل ممكن تريبليس الفترة بتاعت umbilical.
It's very painful. Very painful. لما أشوفها يعني نايم من حوالي أسبوعين patient that transferred from an ER adult with transcutaneous spacing they don't know how to put that rewire. It's very painful. The patient needs to be sedated. Transcutaneous spacing only if there's an emergency. That's it.
Okay.
For just a few minutes maybe, most.
Thank you.
شوف دكتور.
أنا دكتور ميلاد الصغير.
سنة دكتور ميلاد مساعدين.
قبل قال الدكتور هذه البراكتس هذا اللي نحكي عليه. This is our daily practice صراحة. We are not putting any pacemaker if the patient is not symptomatic.
Yes.
Whether it is 55, whether it's 50, whether it's 40,
Yes.
that's one issue. Because what we are talking about, all the management, what we are talking about, they are high risk, either through transumbilical or transfemoral. We can put it. You can do it. But for how long you can stay with it? هذا one issue. طبعا we talk about a situation here in Libya. Another issue, we want to put a temporary pacemaker, whatever, transfemoral or something like that. Where's the pacemaker? Where's the surgeon who will put you? And you are talking about a baby who is less than 4 kg. Where will put the pocket? يعني there's a lot of obstacles. يعني احنا الان نتكلم ان الجلسه البسيطه مش يتكلموا مع الجونيور هذا they don't know what's going on. عرفت؟ فبس they don't give a signal انك just put a transumbilical بعد شيء واحد كتبها transumbilical وبعد شيء what's next؟
مين معنا دكتور مقبول يعني do you plant pacemakers دكتور؟
لا لا.
Yes, I see. I see some patients referred for pacemaker implantation, but as our colleague said, if the patient is asymptomatic, I will not touch him, and I will do an echo. If the annulus, mitral annulus, is not dilated and there's no MR, I don't think he needs it. And then I keep following him, coming to me after 3 months, 6 months or so, and most of them they just do well. If he passes the neonatal period with infant period, he's more likely to pass after that. That's the most time that he needs a tachycardia. If he passes it, he will do that. And then if we need, the problem is providing the epicardial lead. This is the big problem. We always have very shortage of epicardial lead. But once we do it, the last patient we did, we were very cautious, as Halima pointed out. Sometimes even you put a pacemaker and the patient dies. So this time we did it in stages. The patient, I think he was symptomatic. We told the father we were going to put the pacemaker. He disappeared. The patient had a syncopal attack, and then he came back. And then I think he was a rate of 34 or 35 something. So we put it at the rate of 60, and then after 1 week we increased it till we brought him about 80 or so. So we learned the lesson that you don't do it immediately 100 or something, like from 30 to 100. You have to do it gradually, and he did very good. Really the heart became very good, no MR, asymptomatic, thriving well. So I think this is the lesson. You don't do anything if the patient is asymptomatic, keep watching him, and then even if the patient needs a pacemaker, you do it in a gradual fashion. This is our
excellent point.
زي ما قال دكتور حسن, we gain time to gain weight. And nowadays there's a promising, الدكتوراه تكلمت عن leadless pacemaker. هذه الآن promising, يعني you can put في ال 10 kg اللي هو 1 year age. Transcatheter and you put it and الحمد لله تمشي. يعني أنت if you gain time to reach there, you avoid a lot of obstacles there.
Leadless pacemaker definitely an option.
اللي مش عارف الليدلس بيسميكر اللي انت تتكلم عنه احسن مني. يبوت ثرو شيء يعني عباره عن بيج كاثيتر تحطها في الرايت عند يبوش حاجه صغيره زي نوايه التمره يعني. implanted between the trabeculum and then programmed from outside.
طبعا زي ما قلت دكتوره الشيء بيج يعني كان الكترونيك تقريبا 15 سايز فرنش. الايفير اكبر بس الايفير اكستراكت يعني ميزه يعني they're promising everything you can.
بس 15 في 1 في 10 كي جي 15 يعني ممكن تمشي الحال وود كوشن هنا ما يدمجش.
شكرا.
زميلات ممكن نسألوا عن الكوست بتاع الوايرلس بيسميكر؟
والله ما عندي فكره, ممكن تعرفوا.
الليدلس بيسميكر لا زي غالي زي
How much يعني؟
ما اعرفش 20,000 حاجه زي كده.
$20,000.
ايه طبعا اسعار امريكا.
والبيس ميكر ده هيعيش 8 سنين 10 سنين، لا ما ينفعش ونحط واحد جنبه واحد جنبه واحد جنبه.
هو السؤال دكتورة لأن احنا مرات عندنا شورتج حتى الابيكارديال باهي عندنا 8000 و10000 صح دكتور حسن ولا يبدا في صعوبه ان حتى البيرنت يوفروه ومش ديما متوفر بالصحه. احنا لما نتكلموا عليه
يا دكتورة هي المسألة مرات بعض البيشنت يو كان نوت بوت ايبيكارديال مش عارف كم الويتنج
اللي هم جماعة الكارديولوجي يقولوا كانت بوت اندوكارديال.
قصدي انا الليدلس احنا بندخل من الجدر فين لانه كبير تنضرب بشيء تشتك على قبلك رايت فنتريكل وتحطها طوالي يعني. فهي اكسبنسيف I don't say it's خلاص feasible ولكن it's a very promising thing وبعدين قصه البوكت انفكشن والحاجات اللي بتشم اللي very common.
دكتور بلال في كيس
طويل يعني
في حالات ده كيس ثاني
لا سبوراديك كيس انا مع جماعتنا اللي في الرياض هي طبعا لان اغلب الالكتروسيرجن اللي يشتغلوا على اليد هم ادلت في الالكتروسيرجن، جماعه البيدياتريك ما عندهم كومن كيس لكن يعملوا فيها مع بعض يعني 12 كي جي 15 جي اللي هو تقريبا عمره سنه وشهور او سنه ونص لكن زي ما قلت لك اللي قالت دكتور حسن فيري امبورتنت هذه gain time as much as you can. Then we do manage.
We have even 15 years now congenital AV.
في كثير من البيشنت يعني مش اخوانهم زياده تشاهد هو المشكله.
شكرا.
Fortunately, our baby all asymptomatic or growing up without pacemaker. I have one patient got with us. Alhamdulillah. Well, I have one 10 years now asymptomatic. She's playing waiting for. Yes.
Exactly. That's the message يعني. خلاص دكتورة هدى.
The last will present دكتورة هدى الشرشاري. She's a pediatric fetal cardiologist, associate prof. She will present.
دكتورة هدى she will present
Arrhythmia. هي fetal arrhythmia.
Yeah, early presentation of fetal tachyarrhythmia.
Early presentation of fetal tachyarrhythmia. نص
سوري ما قالت لي مشكلتي. لا لا.
So I'm going to present one of my cases that I followed this year. Presented early on with tachycardia. I don't have anything to disclose. So fetal supraventricular tachycardia is a cardiac rhythm anomaly complicating about approximately 1 per 1,000 pregnancies. Fetal SVT usually occurs as an isolated problem, and occasionally it can be associated with cardiac defect. Sustained fetal SVT can be serious because it can lead to poor outcome, including fetal demise because of decreased cardiac output and fetal high drops. So the outcome is usually improved if the fetus is converted early on to sinus rhythm. Management of these rare cases is often difficult and requires prolonged treatment with antiarrhythmic, of course, transplacental treatment. I had this patient who was referred to our center. She's a 25-year-old lady, gravida 3-para-1, came to the emergency room because of vaginal bleeding and cramping at 13 weeks gestation and 66 days, almost 14 weeks. She had unremarkable history except for some caffeine use and cigarette use. She had a healthy son, no family history of cardiac arrhythmias. On initial ultrasound in the emergency room, they noticed the fetus was in tachycardia in the range of 200 beats per minute. So our MFM, high-risk pregnancy, contacted me and they asked me to evaluate this lady. May I ask you to play the video? So I was a little bit nervous because of the gestation. It was only 14 weeks. I never scanned a fetus at 14 weeks gestation. And I was going to scan her and thinking how I'm gonna get the images. So I was able to get good images, as you can see. I used a high frequency curvilinear probe, and I noticed the fetal heart rate ranged from 207 to 214, and I was able to get good pulse Doppler I used the inflow outflow, and I was able to measure the AV and the VA interval and diagnose this fetus with long VA tachycardia with VA interval of 2 or 3 milliseconds. From the 4 chambers view, I noticed the function was good. There was a small pericardial effusion. I didn't see any structural heart defect. So what I did actually when I saw this, I did contact my colleagues, a friend of mine in Toronto, Dr. Yegi. He's the one I usually talk to. He's excellent, known for fetal arrhythmia. And I asked him, what should I do? I am with this fetus with 14 weeks, and it's very early. It's gonna be long therapy. What's gonna be the outcome? So he advised me to start flecainide and monitor the baby and the mom, of course, in the hospital. And he told me probably since it's early gestation, probably it's a long VA tachycardia, probably it's ectopic atrial tachycardia. And he said the outcome might be good, no worries. I spoke also with Dr. Janet Strasburger, my friend, when I worked with in Milwaukee. She scared me a little bit. She said she had similar case and the patient did not made it. There was fetal demise, but she recommended I treat as well. So we decided to treat the mom with flecainide, and I spoke with our MFM group, and she got admitted. They did all the preparation for her, so all the lab workup, EKG, and then we spoke to her, and she was okay starting the medication. So usually the prenatal management, either close observation with no treatment, depend on how is the fetus tolerating this arrhythmia. If it is brief, we don't see it throughout, like if it is not sustained, you can just observe. And usually you give monitor to the mom and she can check the fetal heart rate at home. But if it is incessant sustained tachycardia, we have to treat it as in my case. And delivery usually depend on if there is incessant tachycardia and the fetus presented late, you can deliver, and the plan usually either normal or C-section, depend on the obstetric. So the management and clinical course in our case, she had the fetus had incessant long VA tachycardia, so we did flecainide 100 milligram twice daily. And the mother tolerated the treatment very well. Fetus converted to sinus rhythm within 2 days. And patient was followed closely with weekly EKGs and fetal heart rate monitoring, as I said earlier. She herself bought the fetal heart monitor through Amazon, and she started monitoring the heart rate at home. And I saw her every 2 to 3 weeks, and MFM monitored her weekly. They did the EKGs weekly for her, including the labs and calcium, magnesium levels. And she did great, actually. So they were going to, this is the heart rate, 140 after initial treatment, and then during follow-up, I got another tracing. At 37 weeks, the fetal heart rate remained good. The outcome here, they were planning to deliver her actually on Thursday. I was leaving Friday to come here, and then I contacted our colleagues, the MFM. I told them, no way, I'm not gonna be here in town, and if this baby goes into SVT, nobody gonna manage this baby. Then you guys has to transfer the baby to Ryby. I feel bad for the mom. Let's deliver her a little bit earlier. So they contacted the OB, and they delivered her on Monday, September 30. So I changed the date of birth of the baby because of my travel here to Libya. And I saw the mom and the baby after birth. I went to the women's hospital. They were doing great. I admitted the baby, of course, to the NICU. And the baby continued to be monitored in the NICU. I spoke with, of course, we planned this with we do multidisciplinary team, and we talk about these patients. So the NICU, they were aware, and we had planned, they were monitoring the baby in the NICU. We got the EKG, was normal at birth. And then I asked them to monitor just for 2 days. If the baby does not go into SVT, we can discharge home. And this is the EKG after birth. It's normal for a newborn baby. You see right axis deviation and RVH. And so it's a normal EKG for a newborn. And the baby got discharged before I left to come here, so hopefully no going to SVT. And I asked Dr. Yegi when I saw him in September at the fetal symposium, do you think this baby will go into SVT? He said the chance is 30%. So there's many of them, the flecainide I think helps. So let's talk about now long VA tachycardia. It is a slow, called also slow SVT, and it's either ectopic atrial tachycardia, the different diagram is also PGRT, or sinus tachycardia can be mistaken as long VA tachycardia, so we have to be careful. It's an automatic tachycardia, it's increased atrial automaticity, and as I mentioned earlier, it can start early as 12 weeks gestation. The rate usually is variable from 175 to 240. Majority of them usually they are in the like 200, 210, 220. Usually there is one-to-one conduction, as in our case, and it can be sustained tachycardia. Can we play the video? Did it play? Yeah, this is just to show the slow SVT. Very good. And the management of long VA tachycardia usually